Hello, assalamu alaikum. Can everyone see me okay? Can you hear me okay?
জি স্যার, দেখা যাচ্ছে, শোনা যাচ্ছে।
Is everyone here? Can we start now, or do we need to wait a few minutes for any of the other doctors? I can see we have wa alaikum assalam. I can see we've got 10 people, including myself and the host. So are we waiting for any other doctors? Shall we begin, or are we going to wait for anyone else?
Sir, I think we can start, sir. Later on,
Okay.
the doctors will join, sir.
Okay, perfect. So let me share my screen then. Can everyone see my screen? It should say approach to headache in primary care. Let me know in the chat. Yeah, can everyone see the screen?
Yes. Sir,
Yeah,
we can
great.
see your start, sir.
Perfect. So, okay, assalamu alaikum everyone, and thank you for coming to the session. I was invited to speak about an approach to headache in primary care. So I'll just give you a brief introduction to myself and then what we're going to cover, and then we'll get into it. So my name is Mahibur Rahman. I'm a portfolio GP and a consultant in medical education. So let me explain what a portfolio GP is. So in the UK, to become a GP, you complete 3 years of GP training after having completed what's usually called the foundation program. So it's like a 2-year internship in the UK. So it's 5 years postgraduate in total, and then you have to pass 3 parts of membership of the Royal College of General Practitioners. Then you can become a qualified GP. So a portfolio GP is somebody who works in different roles. So I'm a partner in my own practice. I'm one of the GPs at a secure unit for women with significant mental health illness, and I work in community drug and alcohol detox. And then my other roles are in medical education. So I have been writing various books and articles about MRCGP, GP careers. I'm one of the authors of something called the Prescribing Safety Assessment, which is an exam that doctors in the UK do on prescribing safely. I was an examiner for the General Medical Council for the PLAB Part 2 exam, which if anybody plans to come to work in the UK at some point, you'll sit that exam. And I continue to examine at Liverpool Medical School. I have fellowship of the Royal College of General Practitioners for my work in medical education and humanitarian medicine. And our team at eMedica, we specializing in helping people pass professional exams, membership, to get into specialty training. We've trained now over 62,000 delegates, from doctors applying to get into GP training, doing their membership exams, to GP trainers and examiners. So what I'm going to cover today, we've got an hour and a half or so in total, is I'm going to touch on how to approach the sort of data gathering and the management of some of the key conditions that can present with headache. So we're going to look at history, what kinds of things to ask, what kinds of things really important not to miss, what kinds of things you might find in examination. And then a condition that perhaps because of its chronic nature, because of how common it is, but also because it can be difficult to manage, that you're going to probably see a lot in primary care, is migraine. So I want to go through migraine in detail. So we're going to look at that in depth. Then we'll do an interactive case study. So I'd like you to get involved. I'll pretend to be a patient. I'll get you guys to ask me questions. You can sort of put into practice some of the things we've already covered here. And then we'll finish with a little quiz, just a few questions to try to consolidate the knowledge of some of the things that we've already discussed. And finally, I'll finish with a question and answer session. So if you want to ask anything about headache or about general practice or about anything at all, really, we'll leave that to the end. Okay, so that will be the Q&A. We'll do that at the end of the session, and we'll be finished. We've got from 3 till 4:30, so we'll be finished in an hour and a half in total. We may have a short break, maybe for 5 minutes in the middle, in case anyone needs to use the bathroom or grab some water or something like that. Any questions before we begin? No? Okay, good. So first thing we're going to start with is data gathering. So data gathering, I'd say 90% of your diagnosis is going to be made from your history. Your examination, then, by the time you're going to examine, you should already have a clear idea of what you think is likely, and your examinations are going to help you either confirm that or to refute it, or sometimes from your history, you've narrowed it down to 1 or 2 things, and your headache is what will separate, if you find X, it's going to be this one. If you don't find it, it's going to be this one. So you need to have a systematic approach to headache, because so many different things can cause headache. So the first thing is, the onset. Certain headaches, certain conditions will cause a headache that comes on very suddenly, whereas others will be something that comes on more gradually. So, if something comes on bang suddenly, what you think it might be is going to be different to if they say that they just noticed it. They didn't really notice exactly when it came on, but it was just there, and it just comes on more gradually. The severity, certain serious headache causing conditions, one of the features of it is that they'll describe it as really, really bad pain. It's one of the worst pains they've ever experienced. There's other types of headaches that people might get regularly, that although it's not as severe in terms of how bad the pain is, but it's just because it lasts for a long time at a sort of moderate level, it's a distraction. It can affect their concentration, it affects their ability to work, affects their ability to spend time with their family. Duration. So, is it a headache that when it comes, it goes within a few minutes? It goes within half an hour? Is it a headache that can last a day, 2 days? Again, this is going to help you separate what could be causing it. The location. Is it in a one very specific point? And they can point to it right here. Is it bilateral? Is it unilateral? Is it frontal? Is it sort of temporal? Is it at the back, occipital? Frequency. Do they only get this once in a while? Do they get it every day? Do they get it several times in one day? Do they get it several times in a month? Do they get it once or twice a year? Do they get it every day at the same time? These are going to give you clues as to what could be causing. The pattern. So, if it always comes on exactly 7 p.m. and lasts half an hour every evening for several evenings, that's going to give you a clue. Precipitating and relieving factors. So are there certain things that make it better or make it worse? So, if someone finds that when they bend over, it gets worse, that can give us a clue that it might be something that's causing raised intracranial pressure, space occupying lesion or something like that. Is there something that makes it better? So what kinds of painkillers have they tried? Have they helped? That can be a useful clue. Have they tried non-medication type things? And has that helped? The characteristics of the pain. How do they describe it? Is it achy? Is it like a tightness, like someone's pressing on their head? Does it feel sharp? Does it feel like it's a really deep pain? And then do they have anything else associated with it? So before the headache comes, do they get a feeling that something's coming? Do they find that they get a funny sense of smell, or that they see some wavy lines? Do they see that, they just get a perception, I know it's going to come? Do they find their hearing changes? Do they feel sick with it? Do they find that the light makes it worse? Does noise make it worse? Then they just want to go in a dark room and turn everything off, put headphones on, and that helps. Have they got sort of autonomic or neurological features with it? So these are some of the things that are going to help you narrow down what's going on. And then something else that's really important is to think about not just the features of the symptoms, but to look at the patient in their context. So if someone describes, for example, that they start really getting lots of headaches 2 or 3 months ago, rest of their life, they never really had someone that suffered from headaches. It'd be really important to find out, had there been a change in their life at home or at work in the last 2 or 3 months? Because maybe something setting off, for example, stress is a major cause of headache. So if they've recently changed to a job and they're finding this job really difficult, it's really high pressured, maybe, they don't get on with some of their work colleagues, and so they're finding that stressful. That could be one of the things that might trigger someone to suddenly get headaches. So you've got to look at them in their context in the primary care setting. It's really, really important. So let's look at a few conditions, but we'll just look at what things we might want to examine. So you've taken your history, you've narrowed it down. Some of the things that can be useful to give you further clues or to help you sort of narrow it down further and come up with a diagnosis come in the examination. So blood pressure can be useful, because if someone's got high blood pressure, one of the ways that it might present might be that they keep regularly getting headaches, and they might not have checked their blood pressure before, and they might have high blood pressure and just not known about it. If you've got an older patient, especially if they're older than 50, one of the things you've got to think about is, could it be giant cell arteritis or temporal arteritis? So actually palpating the temporal arteries, that can be useful, because if that's tender, and sometimes they might describe that in their history, that when they comb their hair on one side, it hurts. It's fine on the other side. That can be a useful clue. Neurological examination, because a cause of headache could be things like stroke. All right, and so if you do a neurological examination and they've got weakness on one side and they've got a headache, that can be a useful clue. Fundoscopy, so looking at the back of the eye to see if there's signs of papilledema, and if that's bilateral and then they're vomiting in the mornings, that could be a clue that they've got a brain tumor, for example. And then examining the neck to see if they've got tenderness of the muscles, if they've got stiffness, they find that they can't move. Again, this links back to the history, that if someone, for example, had been in a road traffic accident, maybe they're in a car and another car ran into the back of them, and then they went forward and back, they might have a whiplash injury, there might be some tenderness and a bit of stiffness, and they don't want to move their neck, then they can start getting headaches later associated with that. So these are some of the things to start thinking about when you have a patient present to you with headache, because headache, very common, but there's so many different things that can be the root cause of it. Okay, so let's look at then a few of the conditions, because one of the things when patients present, the majority of causes of headache are not serious things. The most common cause of headache is simple tension headache. So most of these things we can manage in the primary care setting. But we do have some patients that might present with headache, and the underlying cause is something really serious, where they need to be seen in hospital as soon as possible. And so there's some clues that can help us in the history, in the examination, because we don't want to miss these ones. So these are the kinds of things that if you saw in the patient, what you want to do is make sure that they be seen in hospital straight away or as soon as possible. So if in the history it was mentioned that they banged their head, someone hit them on the head, and since that, often they've come with someone, a family member, and it seems like their consciousness is impaired in some way. So you might do a GCS, a Glasgow Coma Scale, and they can't give you clear answers to the questions. Their eyes are sort of closed and they're open when you call their name, or you find a neurological deficit. What kinds of things, type into the chat, what kinds of things, serious, not that common, but serious things might we be thinking about? And might we want to make sure that we don't miss? Type into the chat, get involved. So I'll give you an example. Okay, so someone says that they're a laborer, they're working on a building, and they're working on the second floor. They slipped, they banged their head on the way down and fell down. Now, they managed to get up, they carried on, they went home. A couple of days later now, they just seem more and more sleepy. They seem more confused. That's why their family members brought them to see you. Okay. What kinds of things might we be thinking could be going on with this patient?
Subdural hemorrhage or
Great.
intracranial hemorrhage.
Yeah, great. So we'll be thinking about a subdural hematoma might have built up, or an epidural hematoma.
Hematoma.
There's a hemorrhage, and often there's that delay with that. Great. Okay. All right. So what about someone with a sudden onset neurological impairment? So family member says that they started slurring their speech, their left side went weak, but they said that this had happened a couple of days ago. By the time they brought them to see you in your chambers, when you examine them, there's no neurological deficit. The cranial nerves are they're intact. You can't find any weakness. They seem fine. But the history is that it came on very quickly. And they had a headache, and then suddenly they were slurring and their left side went weak. But it's completely better now. What kinds of things? Or you examine them and they've still got some weakness on the left side. What kinds of things might we be thinking then? Again, something that needs to be seen quickly. Get involved, ladies and gents. Don't worry if you get it wrong. Okay, great. Yeah. So if
Transient ischemic attack or hemorrhagic stroke.
so, if they've still got a weakness and it's more than 24 hours, then it's a stroke. Okay, that we'll be thinking about. If within 24 hours their symptoms got better and you find no abnormality when you examine them, then they might have had a TIA, a transient ischemic attack. Now, this we can manage in the community sometimes. We might want them to be seen, but it might not be something we need to rush them in for if they've had it some time ago. You know, they had the symptoms more than a week ago. You might still want them to see a stroke specialist. Whereas if they've still got a weakness now, and it could be a stroke that's still progressing, that's important that they get seen, because potentially that could be fatal if we don't stop it. Okay. But what about the history is that the pain started quite quickly, so it was sudden, but it started and it wasn't so severe, but then it went up and up and up. Okay. And it went to a peak of intensity within less than 5 minutes. Okay. Then, you know, one of the things we'll be thinking about is a subarachnoid hemorrhage, right? That very classical description is, it's like someone hit me on the back of my head with a cricket bat. Gosh, it just came on suddenly, very, very, and that it's the worst headache I ever had. Now, sometimes one of the things that will give you a clue is that this can cause impaired consciousness, but not always. So it's important that if the history is that it came on sudden and it's very severe, and someone who doesn't normally have headache, you've got to take that seriously. Even if their consciousness is not impaired, we've got to consider that. Okay. Okay, so let's look at a couple of others where it would be important to have them seen quickly, to have more investigations, to, you know, rule out something rare but serious. So what about you've got someone, they're quite young and they come now, they've got a headache, but they're just also feeling unwell, temperature's high, and their consciousness does seem like a little bit impaired. They've got some stiffness of the neck, and when you try to look for papilledema, you look for fundoscopy, they really don't like the light. What would we be thinking about that again?
Meningitis.
Absolutely. So rare but serious. You see, this one we can't just manage in the community. They need to be seen. They need to be assessed. So we'd be thinking about meningitis or encephalitis, so an intracranial infection, but it's serious. What about someone middle-aged and they come with headache, but as well as the headache, they've got very severe pain in their left eye, and there's some redness there. The pupils sort of mid-dilated, fixed. The cornea is a bit hazy. The vision's a bit reduced to normal. They don't normally wear glasses, and they're struggling a bit. Again, what would we be thinking about when we put all of these things together?
Due to retinal hemorrhage,
Anybody else? If you don't want to use your microphone, feel free to use the chat. please get involved.
Glaucoma.
Yeah, so one of the things you'd be thinking about would be acute angle closure glaucoma. If it's painful, that's one of the things that you must think about. Again, you see lots of different things can cause headache. So these are ones that would probably want them to be seen that day. What about things that, again, could be caused by something serious and might need to be seen by a specialist quite quickly? And like in the UK, we have certain things where we'd refer within a couple of weeks, not doesn't have to go to hospital that day because it's not that urgent, but it's urgent that they're seen within a few weeks to be investigated further. And also things that we can't manage 100% in primary care. It does need input from secondary care. So, we had those things they should be seen today. Now we've got some things that still need to be seen quite quickly, but maybe not as urgently. So again, they've got a headache, they're older, they're in their 60s, and they've got tenderness on one side. They say when they comb their hair that it hurts, or you can actually palpate. Then what would we be thinking about? So you should be thinking about giant cell or temporal arteritis. Now, that actually initially we can manage in the community. So you could manage it with steroids, for example, and painkillers. But in some cases, they might need to be seen in hospital as well. What about they've had headache now for a couple of weeks, and they wake up in the morning vomiting. When they bend over, the head feels more painful. The pain's so bad some days, it wakes them in the middle of the night from their sleep. And when you examine them, you see some optic disc swelling bilaterally. So they've got papilledema, it's bilateral. What would we be thinking could be causing it?
Hypertensive retinopathy.
Could you say that again? Sorry, I couldn't hear you. Or type it in the chat. So if someone's got bilateral papilledema, there's a few things that can cause optic disc swelling. Okay, there's a couple of things that can cause papilledema, but if it's bilateral and then associated with vomiting in the mornings, one of the things you'd be thinking about is a space occupying lesion. So a tumor, something causing intracranial hypertension. Okay, what about you've got someone, they've got a headache and they also just feel really sick, and their consciousness, the concentration is sort of, they're a bit confused. They find that they can't focus. They even during your consultation, you're trying to ask them questions and they sort of lose track, lose focus. What kinds of things, again, rare but important not to miss, can cause these symptoms? See, that's quite vague, right? But one of the things that you don't want to miss, let's say they work in a factory and the factory normally has air conditioning, but that's broken at the moment. And so they're in an enclosed space without good circulation. What could be something that we might need to think about? So one of the things, remember, in relation to someone who's got a headache as well as this, is carbon monoxide poisoning. And there was a recent case where you can get this problem as well with gas cylinders, that if it's not ventilated and the gas is building up, you can get carbon monoxide poisoning. Okay, what about things that we can manage in the community? So someone presents to you, they've got a headache that's bilateral. It's mostly in the actual head here, bitemporal, but sometimes they just feel it in the face as well, sometimes in the neck. And when you ask them how it's described, they describe it as it just feels like a band pressing here, a tightening. Sometimes it's tender if you actually press, but sometimes it's not. And when it comes, and they can get it 4 or 5 times in a month, but when it comes, sometimes it will last an hour or two, sometimes it'll last a whole day, maybe even 2 days. What could that be?
Migraine headache, sir.
Yeah, so that would fit with tension headache. Like this is the most common cause of headache, but the key here is the description, the fact that it's bilateral, the fact that they describe it as a tightening or a pressing. This is typical of tension headache. Okay, and tension headache can last sometimes 2 or 3 days, right? And it's one of those things, it may not be very severe, but a low level pain lasting a long time can really have a big impact on quality of life. Okay, what about this one? So it's always on the left, and they describe it as a throbbing. They feel sick, but they haven't been sick this time, but they had something similar a week ago. That time they did vomit. And when they get it, they find that noise makes it worse. So like they turn the TV off, they turn the lights off, they put headphones on, and that seems to help. They just lie in a dark room for a while.
Migraine headache.
This is migraine headache.
Perfect. This is very typical of migraine, right? Okay. So we've done a whistle-stop tour of very serious things that need to be seen straight away, important things that can have a serious cause, but maybe less urgent, and then things that are very common that we should be able to manage in the community. So as I mentioned, I want to look into migraine in a lot more detail because it's such a common, but it can often cause significant amount of impact on quality of life. For some patients, it can be disabling. They can lose several days of work. They can find that they can't, if it's not managed well, they can't continue to do their job. So if we can manage it for them, we can have a big impact on their life. So let's look at how to approach someone that comes with suspected migraine. And in this day and age, one of the things is that sometimes patients themselves will know someone that's got migraine, or will look up things on the internet and come to you and they tell you, I think I might have migraine. So someone comes in, they suspect they might have migraine. What are the things that you want to go through in terms of your history, your examination? Okay, so in terms of data gathering, one of the first questions I'll ask if someone thinks they've got migraine is, where is the pain? And in adults, migraine is almost always unilateral. So that can be a useful clue that, if it's bilateral, even if it's severe, because a lot of patients just think that migraine is a very bad headache, that it's because it's severe, that's what makes it a migraine, not a normal headache. That's how, in some patients' minds, they separate a tension headache to a migraine. But that's not the case, you see. So if they tell you it's both sides and they're an adult, children you often get bilateral migraine. But in adults, if it's bilateral, it's not migraine. All right, so the fact that it's one side, that's really important. How often does it come? How long does it last? So a migraine, again, in an adult, is going to last at least a few hours. If they get a headache and it comes and it's gone in half an hour, that's not a migraine. Children can get migraine that lasts a short amount of time. The nature of the pain, so typically described as pulsating or throbbing, and the intensity, so it's moderate to severe. It won't be mild, whereas tension headache can be mild, like a low-level pain. It will usually be associated with either nausea or vomiting, or both. And again, either with photophobia or phonophobia, or both in adults. You want to find out what could be setting it off, because there might be some patients that they notice now they're getting more of these types of headaches. And there might be a set trigger. And if we can identify that trigger, we can help them to avoid it, we might reduce how often they get it. We can't make migraine go away completely in most cases. It's not something that can just be cured. It's a chronic condition. But if we can identify a trigger factor, so sometimes for some patients, it might be that if they're under increased stress, that sets off their migraine. Some patients, if they don't get enough sleep, and maybe they had really busy time at work, and then they went to a family event, came to bed really late, and then the next day, in the afternoon, their migraine started. And they find that always happens when they've had a really late night, didn't get enough sleep. So then if they know that that's their trigger, they can try to avoid that. Lack of exercise. Some people missing meals. Some people, it's eating certain foods. So Some people will say, okay, if I ever have pizza, I'll get this. If I have, normal bat tarhari, I'm fine. But it's the cheese in the pizza, which normally we don't cook with, all right? So it's maybe for that patient, that cheese is the trigger. And if they avoid that, some patients, if they have chocolate, they'll get a really bad attack. When they don't have chocolate and they only have that on a special occasion as a treat, they're fine. So it's not just general food, it might be specific things. Others, the other way. It doesn't matter what they eat, but if they miss their meal, they're really busy at work, they didn't eat till really late, it's that missing of the meal that sets off migraine for them. And you want to have an sort of detailed understanding of how it's impacting their life. Because as I mentioned, for some patients, when they get a migraine, it can be so bad that they just need to lie down until it goes, and it can last hours, even more than a day, right? That might make it really difficult for them. That you do that once or twice and you're working in an office, your boss might be understanding. You do that several times, the boss might say, look, we need someone to be here to do the work. And so it might be that it impacts that they might lose their job. And so it's really important to them. That's why they've come to see you as their doctor. They want to get this under control. And then medications. So, patients might have just bought things over the counter. They might have just gone to see a pharmacist and tried all kinds of different things. But if you know what they've tried and what's worked and what hasn't, that can be useful. So what are the things that we'd be looking for to say that this is likely to be migraine without aura? That they're having recurrent episodes that last anywhere from 4 hours to days. But in an adult, if it's less than hours, if it's like half an hour, 40 minutes, that's not a migraine. That it's associated with nausea or vomiting or both, photophobia or phonophobia or both. And then usually you want at least 2 of these characteristics. That it's unilateral, that it's pulsating or throbbing in character, that it's moderate to severe in intensity, and that if they just do routine physical activity, when they're having the migraine, even going up the stairs sets it off, okay? As I mentioned earlier, that in children, it can be bilateral migraine. In fact, it's more commonly bilateral in children. And then when to diagnose migraine with aura is that they've got the typical symptoms of migraine, so these things, but that before it starts, they get either visual or sensory symptoms or a dysphasia, that's difficulty with speech, and that these things can develop gradually, and usually after an hour maximum, these reverse. Sometimes they'll get visual symptoms, so flickering lights, or they see wavy lines, or sort of spots flashing. And sometimes they get sensory symptoms that before it comes, they just get pins and needles. Okay, the pins and needles, just like a numbness here, and then it comes on the same side usually. Okay. In terms of management, if they've got the headache right there and then, what the guidelines that we use in the UK, the NICE guidelines, what they recommend for acute treatment for adults is that combination therapies are the most effective. So a combination of an oral triptan, so something like sumatriptan, 50 milligrams, 100 milligrams, with either an NSAID, so ibuprofen, diclofenac, these kinds of things, or paracetamol. The key is to have a triptan as the base, because it's the most effective acute treatment for migraine. You can add something to it, okay? There are alternative triptans, there's lots on the market. What you shouldn't use are ergos. About 20 years ago, we used to use these like third line, and we shouldn't use opioids. So things like codeine, dihydrocodeine, tramadol, these are not good for migraine. They're addictive and they can cause long-term harm. And then even if the patient's not being sick, consider giving them an antiemetic, because they'll often have nausea, but it also has other benefits. So, metoclopramide, domperidone, prochlorperazine, even if they're not being sick, even if they don't feel sick, you want to try and prevent that. It can be useful. And anyone that's on a triptan, it's important that we follow up to see how often are they using it, are they having any side effects, how are they getting on with it, okay? Then if they're vomiting and they're vomiting such that they can't really keep down any tablets, then you can consider non-oral triptan. So you can get zolmitriptan as a nasal spray, you can give a subcutaneous injection of sumatriptan. You can also give non-oral NSAID, so diclofenac as a suppository, that's an off-label use. Non-oral antiemetics, so things like prochlorperazine, you can get as a buccal preparation, just put it under the tongue, okay? Domperidone is available as a suppository, things like this. Now, some patients, they don't want to have a combination. So if they want a monotherapy, you can just give an oral triptan as monotherapy. You could also just give ibuprofen at a high strength as monotherapy. And then something else that could be used is aspirin, high dose, 900 milligrams, okay? Paracetamol usually isn't very effective on its own in adults in migraine. For children with migraine, first line would be either an NSAID like ibuprofen or paracetamol. And if that didn't work, then you might add in a nasal triptan rather than an oral triptan for older children. Okay. So someone said that a new drug's available in Bangladesh, Lasmiditan. So that's a brand name. It's not something that's available here, so I wouldn't be able to comment on it. If you know what the actual drug name is, the generic, I could look it up for you. So let's try and put some of the things that we've talked about so far into an interactive case. So I'd like you all to get involved. I'm going to be the patient, okay? And we've looked at diagnosing someone that might have acute migraine or that might have migraine as to what to look for to say this is migraine, how to manage it. Now we're going to look at someone who you've seen and you've diagnosed with migraine and you gave them sumatriptan and they've come back to you now, okay? So the patient is 44, male, known to have migraine, and they're basically, you gave them sumatriptan to take for when they have their acute attack. So I'm the patient, okay? You're going to be the doctor, so I'll answer your questions as if I'm the patient. I just want to see what kinds of things you think are important to ask in your data gathering. Then I'll ask you if you want to examine and what you want to examine, and then we'll look at where we take it from there, okay? So let's start. Would someone like to start off? I've come to your chambers, your clinic. Anyone like to volunteer to start? You can use the raise hand feature and I will anybody put your hand up and start. While you've done that, someone just mentioned that lasmiditan is the generic name, so I'll have a look at. It's not something that we've used here. Okay, so lasmiditan is suspended in the UK, and so it's not used because it's deemed that it's not cost effective. So we wouldn't use it. It wouldn't be recommended here. And in fact, they've stopped even pursuing a license for it here. So I'd stick to things that there's a long history on and that we have safety data on. So like sumatriptan, been around for a long time, we have good safety data on it. So let's get started now with this case. Can I get a volunteer, or would you like me to pick someone if no one's going to volunteer? Everyone's very shy today. Anyone got a camera that works? You could turn your camera on. Nobody. Okay, I'll tell you what then. Let's do it together. All right. I'll let you get involved. I'll start off. Okay. A good way to start is, after you've done your introductions, to ask the patient a nice open question. How can I help you today? What would you like to discuss today? Okay. So let's say you've asked me that. I'm the patient. Doctor, I've been taking that tablet you've been giving me, and it is good sometimes, but like sometimes I have to take it again. And I think I need something stronger because I'm getting too many of these headaches. It's starting to affect me really badly. So I think I need something stronger, doctor. Okay, so that's the patient's opening line. Does anyone want to ask any questions? What questions would you like to ask the patient? Anyone there?
Sir, I think I think I have to ask the patients about the nature of the headaches and whether this headache is associated. Also, is a case of non-migraine, right, sir?
So let's yeah. So it's a known migraine. So let's do that. As your mic's working, ask me.
Sir.
I'm the patient. Ask me how you'd like to ask me.
Sorry, sir, I can't understand you. Can you speak loudly, sir, please?
Yeah. Ask me the question you'd like to ask me. I'm the patient. You're the doctor.
Oh, okay, sir.
We're doing a role play. Just ask me the question.
So how are you, sir? And
just told you,
what
doctor.
trouble you right now?
I just told you, doctor, it's these headaches. I think I need something stronger. You know, that tablet you gave me, it's good, but I have to sometimes use more than once. And I'm still getting so many attacks now. It's affecting me really badly. And so I need something stronger, doc.
Okay. Is your headache is related with any other things? Like, do you have any new source of anxiety or any causes that may increase your anxiety or something like that?
My work is really stressful, doc, but to be honest, I don't really want to talk about that. I just, if I can get my headaches under control, because I can't do my job properly, that's actually making it more stressful. So I think if I control this, my stress will go down. Okay.
So how should I ask, right?
But let's see if anyone else wants to ask anything else. Anyone else, either put your microphone and ask me, or you can say in the chat, what other important questions do we need to ask this patient? Remember, they're known to have migraine.
So whether it is associated with vomiting or not, is this a question to relevant in this case? Is there any vomiting or not?
Well, doc, I don't normally vomit with my migraines, but I feel sick, you know. So I've not vomited, but I have like whenever it comes, especially at the start, I feel really sick.
Sir, question is, it is from in perspective of previous on out of 10, if I mark, if previous one is like 5, now it is how will you mark, or it is increase in frequency or like intensity like that?
Yeah, doc, it's both. So they're stronger, my headaches, when they come. Like if previously, let's say it was like a 6, 7, I'd say it's like an 8 now, but it's coming more as well. And so I'm having to use more and more tablets, and it's starting to affect me that, you know, I've had so many days off work, my boss is getting annoyed. Okay, so someone's asked, any habit of tea, coffee? Oh yeah, so I have a lot of coffee. So I'll have one first thing in the morning, and then I'll have one, like, you know, coffee break in the morning at work after I've started, and then I'll have one after lunch. It just, you know, like, it keeps me going, gives me a bit of energy. Someone else has asked if I take any regular preventative drugs. Now I've got that tablet you gave, doctor, sumatriptan. So I take that as soon as it comes, I take it. And then if it's not got better, you know, if it's not sort of seeming to work, I take another one later. But I just think maybe I need something stronger. What do you think, doctor? Do I need a stronger one? Is there a better one than this sumatriptan?
So it is natural that you will need you may need a stronger anti-migraine medications gradually, because it is, you know, I will counsel the patient, because it is a lot of patients may present like this type of symptoms after some days or some months or some years. The dose may need increases. It is quite natural. It is you know, it is quite normal for the patient. Some patients.
Okay. So I'm going to get something stronger. That's what I heard from you, doctor. That's great. What's that stronger one called? Or do I just need to take more of this one?
Sir, I can increase your dose of this same type of pill, or if it is not yet controlled by this medication, I will prescribe some painkiller like NSAIDs or something like that, a strong painkiller.
Okay. Anyone else got any other important questions you'd like to ask before we go to think about maybe examination, and then we'll talk about management? Anyone that hasn't said anything so far or not got involved in the chat, try to get involved. Don't worry, this is how you're going to learn, right? Okay, so just get involved. That's important. Okay, so let's have a look at, we touched on some of this earlier, but let's have a look at some of the things that will be important. So first thing is that although someone's got a known migraine, it is very important. Someone could have a known migraine, and if it's getting more severe and coming more frequently, the most likely thing is that it is poorly controlled migraine. It's someone just having more attacks. Okay, and there could be a reason for that: the increased stress, some of the other things. We'll talk about this. You can see one of the things you want to do is you want to ask a few questions just to make sure that it isn't something new on top. So has it changed in any way, or does it feel exactly the same as the migraines you usually get, apart from that it's stronger and coming more frequently? Like, for example, if I've always had it on the left and now suddenly it also goes down my neck, that's a change, isn't it? If I've got visual symptoms, which I don't normally get, like I always get sick with it or feel sick with it, but I don't normally get double vision, but now I'm getting double vision, you'd be worried, right? Could it be something new? So that'd be really important just to rule out, has it changed? Could there be something, someone can have a chronic condition and then they can get a new condition on top of it, right? So you want to take a brief history of the actual headache. So again, well done, we asked about severity, the character, is it the same side that it usually is? Does it go anywhere else? How long does it last? Do they, imagine someone that didn't have aura before and now they're getting aura. That's a change in the nature of their migraine. Okay, slightly different diagnosis, right? And then triggers and relieving factors, things that might make it worse, might make it better when they've got it. We asked about stress. That's really important. How are you sleeping at the moment? That would be important. Again, lack of sleep could be a trigger. Any recent changes in diet? Again, how long has it been that it's been getting stronger and coming more often? Okay. And then something really important is if there's any, like if it was 2 or 3 months ago that it started, was there anything that happened? Sometimes someone doesn't associate it, but like sometimes someone can be in a small car accident. Just, like sometimes someone bumps you, okay? And they don't feel the pain straight away. And a couple of days later, they've got pain in the neck, and then their headaches are getting worse and they don't associate it, you see? So things like that, it'd be important to ask about. But something really important, if someone's getting a known headache disorder like migraine, and they're now saying that they're getting a lot more of the headaches, you need to be very precise about finding out how long they get the headaches, how many they get in a month, and how much they're using their tablets. The reason for that, anyone know? Why is it important to get the specific details of how many tablets they're using, or how many times they're using their tablets, and how many headaches they're getting? Because of a condition called medication overuse headache. Okay, so as part of your history, you want to assess to rule that out in someone who's got known migraine, for example. So you ask about, how many tablets are you taking each time you get a headache? How many days in a month are you using tablets for your headache? How many days are you getting a headache? Are you taking anything else over the counter? You gave them sumatriptan, and then someone mentioned you might add NSAIDs. A lot of times people will buy ibuprofen over the counter, just get it from the pharmacy. So to diagnose someone with medication overuse headache, what you're looking for is that they've got a pre-existing headache condition like migraine, that their headaches are there at least 15 days a month. Now, that doesn't mean that they're having 15 migraines a month. Why? Because sometimes one migraine could last 2 or 3 days. So someone that gets 8 or 9 migraines in a month might have headache for more than 15 days in a month. But essentially what we're looking for is they've got headaches more days than they haven't in a month. You see, if you're having it, 15 or more days, at least half of the days you're having headache. And then overuse is considered when it's happening regularly. So at least for 3 months, they're using a lot of tablets, and overuse is considered 10 days a month or more that they're using triptans or opioids. They shouldn't be using opioids in the first place, but sometimes people just buy them, don't they, from the pharmacy, codeine tablets, for example. Or if they're using simple analgesics like paracetamol or NSAIDs, that they're using it 15 days a month or more, their tablets, that's considered overuse. Now, why is this important? Because if someone's got medication overuse headache, the management, anyone know the management? The management is to stop all headache medications for a month. Now you can imagine, I'm getting even more headaches and you're telling me I got to stop all my tablets. If I don't understand why, I'm going to think that this is not a good idea. The reason is when they overuse it, it paradoxically causes a headache because they're basically overstimulating the receptors. And so you basically need a reset. You just stop completely all headache medications. Then you restart one at a time after a month. And in a lot of cases, this starts reducing the frequency of the headaches. But if they didn't understand why, you can see now this patient, if you don't ask the details, you might not know if they're overusing their medication or not. That's why it's important to get the details, okay? Exactly how many number of tablets, how many days each month are they using tablets, how often are they getting the headaches, how long are they lasting? This is really important. Right, how about this now? What would you like to examine for this patient? What kinds of things? So let's say now I'm not overusing. So you assess for this, and it turns out that I am having headaches probably 15, 16 days a month, and I'm missing work 4 or 5 days now in a month. But I'm only using, because I'm only using the triptans at the start of the headache, I'm using the triptans maybe 8 days in a month. So I'm not quite there, but I'm at risk of getting to overuse if we don't do something about it. So what would you like to examine in this patient? Type into the chat. While we wait for that, someone's asked, how would you deal with an attack when the medication stopped? So essentially, they just have to put up with it to allow everything to reset, basically. Because they've overused it, their system needs to be cleared out. And so that's why, again, they need to be counseled. They need to know they may get headaches when we stop all the medications, but that putting up with that pain in the short term will help them reduce the frequency afterwards, once it's cleared. And then we'll restart their medication after that. Okay. So what would you like to examine for this particular patient? First of all, if they haven't got medication overuse headache, what have they got? You've got someone that's got increased frequency of their migraine, a poorly controlled migraine, and it's starting to impact their work and their quality of life. This is a patient that we might consider for prophylaxis. Remember that triptans are not preventing the migraines. They're just dealing with the acute attack. But there's someone that might benefit from having something as prophylaxis to prevent the migraines in the first place. This is one of the things that we often see in, it's the chronic nature of migraine, is that some patients, some patients, they only get migraines once or twice a month because they know what their triggers are, they avoid them. And when they get that, sometimes you can't, like, if you know that when you don't get enough sleep, you're going to get a migraine, you do your best to get enough sleep. Sometimes you can't avoid it. Okay, you had something busy happen at work, then you had to pick up a relative from the airport and you got home really late. You can't help that. These things happen sometimes. You had to go for, a long on call and there was an emergency at the end and it ran over. You didn't get enough sleep. You might get a migraine the next day. Okay, did you see? But when they get it, they use their triptan, they're fine. But some patients, they're getting it, again and again. And if it's starting to impact their daily living activities, starting to impact their work, we might want to consider prophylaxis. Okay, so things to examine. Check their blood pressure. Again, if that's raised, they could have something that might be making, why is it coming worse now, right? Or why is it coming more frequently? Check their pulse, have a look in the back of their eyes. Again, want to rule out some of those other serious things that could be there on top, right? Okay, we want to make sure they're not there. But also we want to think about, is it safe to give the medication that we're going to give for prophylaxis? So type into the chat, if you've got someone with increased frequency of migraine and you think they need prophylaxis, what options do we have? What medications could we consider? Are there non-medication options that we could consider to prevent migraines, to act as a prophylaxis. So something they take regularly to reduce how often they get the migraines in the first place. Not everyone needs this, but these patients that have lots of attacks, it can be useful. So type into the chat, what kinds of things?
Sir,
Any
first of all, the patients may, I may advise the patients to reduce the intake of his coffee or tea, because in his works he said that he takes lots of coffee. So if you reduce the frequency of taking the coffee, I think the headache will somehow it
Great.
resolves.
So excellent. So this is why it's so important in the history to find out about possible triggers and possible things that might be setting it off, because then you can work on trying to eliminate or reduce those. Okay, so yeah, that's a great idea. So if someone is drinking lots of coffee, see if cutting that back might help. Okay, what else? You can see that's a non-medication option, right? That's something the patient can do that might help to reduce their frequency of their headaches. Let's say they've tried that and they've come back to you again. Look, I've cut it out completely now. I'm still getting them. Anything else that you might consider?
So I think then the lighting in his room, or whether he or she works, is there any relation between lighting of his office space and its migraine? I don't know, sir, actually. Or taking any chocolates, any form of chocolates containing caffeine may increase the headache.
Great. So again, we look for possible triggers. The diet, the caffeine, and let's say, okay, he's eliminated everything that he can, but he's still getting lots. So what options are there for medication? Let's say now we think we want to try a preventative medication to reduce the number of migraines he's getting. We're not saying he's going to get zero, but to reduce how often they come, hopefully. What are the options for prevention, for prophylaxis? Anybody know?
So
Beta
drugs
blocker.
can,
Okay, great. So someone said a beta blocker. Great. Yes. So propranolol is often used as a preventative for migraine. That's a good option in some patients. Any others?
So he can take a leave, sir. So he can take a leave for 7 days or 10 days, so that all kinds of anxiety, and if there is a lack of sleep and sometimes tension headache, or he can take a tour or something like that, sir, for refreshing or relaxing.
Great. Yeah. So again, if stress is a trigger, reducing the stress, that's great. So, but yeah, in terms of medication options, someone else mentioned amitriptyline, and the third one that we would use in the NICE guidelines is topiramate. Now, of course, you've got to look at these and see if they're suitable for your particular patient. Okay, so let's say this patient's got asthma. You see, we wouldn't want to give them a beta blocker because that might make the asthma worse. So then you might think, okay, maybe amitriptyline is a better option for that patient. If you've got a female patient with migraine and they're of childbearing age and they're trying to start a family, then topiramate would not be safe because that's not safe in pregnancy. So then whereas a beta blocker might be an option for that patient. Okay, so you could consider giving some preventative treatment. So these are the three sort of that we would commonly use here in the UK: topiramate, propranolol, or amitriptyline. And something recently been seen in some studies is that you can add to that, just suggest that they get themselves a vitamin B2 supplement. It's been shown that it can be useful. Now, something important is this, they need to be counseled. This isn't going to, it's not a miracle cure. It's not going to take your migraines away. You still need to look at the things that are maybe setting them off, as you've suggested, reducing stress, reducing their caffeine, if they've got diet triggers, trying to eliminate those things. But what it might do is reduce how often they get the attacks so that they're not having to, miss work. They're not having to use as much medication, because we don't want them to get to the point of medication overuse. And then it's important to also know that they still should use the triptan for when they get the acute attack, because these aren't going to do anything when they're having an attack right now. They're to prevent it, because otherwise what patients might think is, oh, you've told me that, and this is why it's important we're careful in our language. This is not stronger or better. It works in a different way. This is trying to prevent you getting the attack in the first place. But sometimes you might get it. When you get it, this is what you still take to try to actually control that acute attack. But this isn't stronger or better, you see. And similarly, like if the patient takes sumatriptan and they're taking 100, which is the top dose, and it's helping. If they suddenly change to a different triptan, it's unlikely that it's going to be any better or worse. You see, it's a class effect, isn't it? Right? It may be that if they're taking it orally and this patient wasn't being sick, but they were nauseous, that if they are being sick, then yes, it might be that taking in a different way, a nasal one or an injection might help, okay? And the other thing is that you might also recommend that they take an antiemetic, because even though they're not being sick, they might think, I don't need to take a sickness tablet, but it can help, okay? In terms of follow-up, if you give them for prophylaxis topiramate, you should follow them up in a week to see if they're having any side effects, how they're getting on. If they're going to be given a beta blocker amitriptyline, they don't work as quickly. So you'd want to give them 2 or 3 weeks of trying it before you follow up to actually see if it's worked, okay? And that's something important if we think about the interpersonal and communication skills aspect, is that it's really important to explore the idea that a patient often thinks that, you know, I just need something stronger. It's not sometimes that they need something stronger. There isn't a higher dose of sumatriptan. We don't want them to take 200 milligrams in one go. It's that they need different things to do different jobs. Sumatriptan is stopping or helping the pain when they've got the acute attack. This is going to reduce the chance that you get one in the first place. And then if you think someone might have medication overuse headache, it's important that you're sensitive in how you approach the questioning. Because if you suggest to a patient that they're misusing medications, they can get really offended. It's not that they're misusing, they're taking lots because they're getting lots of headaches. That's a natural response. And if they need to understand that sometimes taking lots of headache medications can actually cause headaches because of the way that the medication can actually interact with the senses, okay? And then the other thing is about, if you're going to have a patient-centered approach to care, that like there might be a patient that, like I did in the role play, so look, I don't want to talk about the work situation. That if you say, look, you must tell me about what's happening at work, that's quite doctor-centered. That sometimes people don't want to, you know that this there, you can say to them, well, if you can reduce that, you might find that it helps. That's why I was asking about it. But if they absolutely don't want to talk about it, okay, you've noted there is some stress there. You can still mention that that might help to reduce it. But if someone doesn't want to give you the details, you can't force them, you see. So it's important to accept their choice about it. Okay, right, so I want to do a little bit of a quiz now. We're going to do just a few exam style questions as a way to consolidate the knowledge of some of the things we've talked about already and to revise some of the conditions that we've already discussed, okay? And then what I'll do after that is, if we've got time, perhaps we'll do one more interactive case. Otherwise, I'll leave some time for questions and answers. So let me get through these and then we'll see how much time we've got left. So we've got about 25 minutes left. Okay. Are we okay to carry on? Does anyone want a 5-minute break?
So please carry on.
Okay, good. So I'm going to show you a question, okay, on screen, and I can see that we don't have a poll function in here. So what I'll do is, don't type any answers yet, because I want everyone to have a chance to think about it. So I'll give you just over a minute to read the question and think about it. And then when I ask you to put the answers, then you can put the answers in the chat, okay? But until I say, please don't type in, because someone else might still be reading. And if you put an answer into the chat, it might spoil it for them, okay? So please don't put anything in yet. I'm just going to share a question and then I'll turn my video off. I'll give you a minute to have a look at this. Here we go. Okay, so type into the chat your choice, A, B, C, D, or E, of how you're going to manage this patient. And after you've done that, I'm going to ask you to tell me what you think the diagnosis might be. So type into the chat first. I'd like to see everyone put in an answer. Don't worry if you got it wrong, doesn't matter, okay? This is how we learn. But I'd like everyone to put something. So I'll give you another minute for everyone to put in a response. You're just going to type A, B, C, D, E, whatever you think is the right management for this particular scenario, okay? If I had a poll, I'd launch it as a poll, but we can do it this way. And I'll just count up, you know, how many say A, how many say B, how many say C, and so on. Okay, a few more seconds. I can see 4 people, 5 people so far have committed to something. Okay, that means that at least 5 people haven't, because I'm not going to give an answer, and then, but there's 12 people, so I should see 11 answers. 1, 2, 3, 4, 5. Okay, less than half of you have responded. I'll give you 5 more seconds. Please put something
Answer
down.
B. Answer B, sir.
Answer B. Okay, so we've got 1 B, we've got 3 A's, 1 C, 1 E. Okay, so let's look at it the other way. The management is actually the second step. The first step is to look at this and think, what do you think the diagnosis is? So type that into the chat. What do you think the diagnosis is?
Tension
High
type of
challenge
headache.
question.
Tension.
Okay, this is a membership level question. Okay, so I've taken this question from one of my membership preparation courses. So don't worry if you struggle with it. That's okay. We're doing it to stimulate learning. So what do you think the diagnosis is? Type that into the chat, or tell me.
Tension headache.
Okay, so someone says tension headache. Anyone else? And you can see that if you thought it was tension headache, that perhaps aspirin
Headache
might
is a diffuse
okay.
headache and severe.
Okay, but yeah, like for tension, a simple analgesic might be better. That's not one of the options here, but okay, yeah, trigeminal neuralgia, someone said. Okay, what else? What are the possible diagnoses? Don't worry if you got it wrong, just have a go.
Generalized anxiety disorder may be DD, sir.
Okay, could be generalized anxiety disorder, someone said. Well, generalized anxiety disorder can present actually in the primary care setting with headache. It can also present with things like stomach ache and, you know, and so on. But some really important clues here. So the fact that it came out of the blue and it came on in minutes and it's severe and they've vomited. That's really, really important. Okay, so generalized anxiety disorder, typically the kind of headaches you're going to get with that tend to be tension type headaches. So those usually are not severe, they're normally mild to moderate, usually would not be associated with vomiting, okay? Now this is a very young patient as well, and it's come out of the blue. You see, that suggests that they don't normally get headaches. They're not someone that has a known headache problem like migraine, because then it wouldn't be out of the blue. They, you know, would be used to having them. And they have been stressed, but that, while stress can cause headache, stress isn't going to cause this kind of headache. So the correct answer is actually D, which nobody picked. This patient could have a subarachnoid hemorrhage. So the fact that it's sudden onset, it's severe, and it's out of the blue, unusual for them, diffuse. Typically, the headache in subarachnoid, it goes to peak in less than 5 minutes. So the fact that it came on in minutes, that's a really useful clue here. Okay, and so you have to take something like this very seriously. One of the things is that the fact that their cranial nerves are okay is a distractor. It does not mean, it doesn't rule out. Sometimes with subarachnoid, someone will have you know, reduced consciousness level, but often that's when they've got a very big bleed, and you don't want it to get to that point. Okay, so you know, the fact that out of the blue, severe vomiting, and that they don't normally get this kind of thing, that's really, really important. So anyone presenting with a sudden onset, severe, unusual headache, we have to consider that it could be there. We're not saying it definitely is, because you can't actually clinically make a diagnosis of subarachnoid. You can suspect it, and you can confirm it is with imaging, isn't it? So, you know, they'll need to have a scan. They'd have a whole load of other things as well, but it needs to be seen in secondary care to rule it out. Okay, let's do another one. I'll again give you time to look at it. I'll give you just over a minute, and then I'll ask you to put A, B, C, D. Okay, please feel free to type your answers into the chat, or let me know if you can't use the chat. A, B, C, D, or E. Okay, so 2 people so far. I'd like everyone to get involved. Last time, half of you didn't pick something. Commit to something. Don't worry if it's wrong. It doesn't matter. This isn't an exam. This won't count towards your grade for your certificate.
Answer
far we
B,
have-
sir. B. Answer B.
B or D? Sorry, did you say B or D? Bravo or Delta? Okay, so we've got D, E, D, E, E, D. Okay, so most people have picked somewhere down here. All right, good. So again, it's a really hard question, all right? You can see from the description, what do you think the diagnosis is? First of all, type into the chat. From the description here.
Migraine.
Yeah, perfect. Okay, this fits migraine, doesn't it? They've had multiple episodes. It's unilateral, associated with vomiting, phonophobia, photophobia, severe last hours. Okay, so currently he's got a headache that's been there 3 hours. He's just taken some paracetamol. That's not helped. Examination's normal, so it suggests that it's not something else causing it. It fits with migraine. Okay, so the correct answer is E. So well done. A few of you picked E actually. So ibuprofen 400 milligrams and then nasal sumatriptan. Why nasal? Because it's 15. And so we talked about this earlier. In older children, if they're going to have a triptan, nasal is preferred over oral because research shows that it's more effective in this age group. Okay, let's look at some of the others and why they're incorrect. So the most popular answer apart from E was D. The reason D is not correct here is because of this option. Ibuprofen's fine, okay, and 400 milligrams a decent dose. It's because we don't give metoclopramide to adolescents. Anyone know why? What's the side effect that metoclopramide commonly causes, and more so in adolescents, which is why we avoid it? There are other antiemetics we can use for a 15-year-old, but we wouldn't use metoclopramide usually. Anyone know? So it can cause extrapyramidal symptoms, especially tardive dyskinesia. And so it's not recommended to give metoclopramide to adolescents. That's why this one's out and this one's out. Oral triptan, if he was an adult, if this was a 20-year-old, then oral triptan would be fine. Why not C? Why don't we give aspirin to someone who's 15? Anybody? Again, if it was 18, aspirin would be fine, although we normally give 900 milligrams. But why wouldn't we give it to a 15-year-old? Because of a risk of Ray's syndrome, okay, which can be fatal. So we don't give aspirin to under 16s. So that's why C is out. All right. So very challenging question again. So don't worry if you got it wrong, but it allows us to stimulate learning. Just a reminder of the diagnostic criteria for migraine. You can see you have them. These are taken from the British Association from the Study of Headache, that they should have at least 5 attacks that fit the typical description of headache before we say it's migraine. Like the first time you can suspect it, but if someone has it once, a very typical migraine-like headache, but they never get it again, you can't say it's migraine, because the definition of migraine is that it's a chronic condition, that the headache lasts at least 4 hours and can sometimes last days. Where I've put an asterisk, that's not required actually for children. Children can get a migraine that lasts an hour. That it has at least 2 of these characteristics. Unilateral, again, the asterisk means in a child it can be bilateral, but in an adult, unilateral, pulsating, moderate to severe, not mild, and aggravated by routine physical activity like walking or climbing stairs. And so what they do is, because they don't want it to be aggravated, they avoid walking, they just lie down. And during the headache, they've either got nausea or vomiting or both, or photophobia, phonophobia. Okay, again, the asterisk means children don't need this. And then E, not attributed to another disorder. You don't find something else on examination that makes you think, okay, although it looks like migraine, they've got papilledema, and I think it's probably a brain tumor. There's not something else that is likely to cause it. Now, we talked about the management. That first line for an adult would be an oral triptan with something, either an NSAID or paracetamol. But if you've got a 12 to 17-year-old, paracetamol or an NSAID would be first line. And this patient had already tried paracetamol, okay? And then if that doesn't work, you add in a triptan, but nasally, not orally. And you would consider adding an oral antiemetic, but because we don't use metoclopramide in children and also actually in elderly, alternatives, something that would be useful would be something like prochlorperazine. Aspirin is suitable for an adult, but not for under 16s because of a risk of Ray's syndrome. And then opiates and ergos we talked about earlier that we wouldn't recommend. So just a recap, we already covered this. Okay, so let's do one more just to see if we remember. We talked about this topic. Just want to see if we remember the diagnostic criteria. Here we go. I'll give you. Again, look, these are high challenge questions, so don't worry if you get them wrong, but just get involved and have a go. Type A to E into the chat. We touched on this earlier when we did the case study. I just wanted to do a recap to make sure we've got it. Okay. Give you 30 more seconds and then we'll wrap up and then I'll do my summary and I'll take questions and then I think that will be the end of the session. So far we have A, Abba, and another B. Great, I think that's enough time. So the correct answer is B. All right, so remember we talked about that regular overuse is 3 months or more. So the reason A is incorrect is that it's just 2 months. If they did it for another month, then because they are using a triptan, that would have become overuse. But because it's only for 2 months, we wouldn't class this as overuse yet. Okay, so it's got to be 3 months at least. All right, and that for triptans, it's 10 days a month or more. So triptans, so they've got a triptan 10 days a month or more for 3 months. For simple analgesics, NSAIDs, so aspirin, ibuprofen, paracetamol, although it's for enough months, 10 days isn't enough. For these, 15 days is considered overuse. Whereas for triptans, it's 10 days, because that's why B is the correct answer. Okay, so again, we covered this earlier. Remember, to say that someone's got medication overuse headache, they've got to have a pre-existing headache disorder, then they have the headache occurring at least 15 days a month or more, and then regular overuse for 3 or more months. Of a triptan, 10 days a month or more, or opioids, although they shouldn't be using those, or ergotamines, although they shouldn't be using those, but also for combination. So someone taking a triptan and paracetamol, triptan and NSAID, 10 days a month is considered overuse. If they're using simple analgesics, aspirin monotherapy, NSAIDs, 15 days a month or more is overuse. Okay, right, good. So look, to summarize, headache is a very common presentation that we're going to see in primary care. In most cases, what's going to cause it are things like tension headache, things like migraine. They're going to be not serious causes. And sometimes with something like migraine, although it's not a serious cause, it's a chronic condition, it can have a serious impact on quality of life. Okay, but one of the things is that there are those less common and some even rare but serious causes that we have to keep in the back of the mind so that we can ask the right questions, do the right examinations to rule those out, because missing those can potentially have a big impact on the outcome. And if someone has got a chronic condition like migraine, education is a really important part of the management, because as often as you identified very rightly, things that might be in their lifestyle, in their work, in their diet, in what they're consuming, like caffeine, that if you can help them understand that that can set it off, if they can eliminate or reduce that, it can help improve their outcome. And so they're more likely to do it. So if you just tell them, cut back coffee, and they don't understand why, because if you highlight how that can actually set it off, and they see, when I have less coffee, I have less headaches, that's better for me, I can find something else that I can have that won't set it off, that can make a big, and to understand the nature of the illness, that it's not something that we can just cure completely, but we can manage it, especially if you work with them. Okay, so any questions that you'd like to ask? I've got about 5 minutes for Q&A because we're nearly at the end of the session. Anything that you'd like to ask, feel free to ask. The other thing, if anybody has any questions, if at some point later on you think that, I hope that you complete your certificate and you develop as a family medicine specialist in Bangladesh, because it's much needed that we promote the specialty. It's a really important thing, and that'd be great. But some of you might have some questions. Some of you at some point might want to come and do some training in the UK. Feel free to get in touch. We specialize in helping people, succeed in membership exams and so on. But also feel free to connect with me on social media. This is where you'll find me. So if anyone's got any questions, ask in the chat. I'll be happy to answer them. And just also like to say a big thank you to Dr. Qabir Ahmed Khan for inviting me to teach this session. Do let me know as well if you found it helpful, if it's been useful to learn in this way, to do some case studies, to do some covering of the theory, and do a little bit of a quiz to consolidate as well. And then any questions, ask in the chat. I'll hang about for the next 5 minutes.
So actually what you have taught 1.5 hour, actually sir, it is little bit difficult, seems little bit difficult for us, because now we are doing a certificate course, and the question seems to be highly standard for like MRCB, or like will we face this type of question in our final exam? This is my question, sir, in my certificate course.
Probably not this type of question, because as I mentioned, the questions I've given you, they're taken from our membership courses, so MRCGP, that's a higher level than a postgraduate certificate. But the purpose of these questions isn't, as I said, this is not your exam. The purpose of these questions, though, is that you do hard questions and get them wrong, you learn from it. It's to stimulate learning so that you understand the learning points. Okay.
Thank you so much, sir.
You're welcome. Okay, so someone said that flunarizine is commonly used as a prophylactic drug in Bangladesh. So that's something, we only have 3 drugs that we use in the UK for prophylaxis of migraine that have a license, and they're the ones we mentioned. So amitriptyline, propranolol, topiramate, they're the only 3. We have other things that we might use that are non-drug. So if that failed, actually there's evidence-based that having acupuncture can be helpful for some patients as a prophylaxis for migraine, but we wouldn't use flunarizine in the UK. So again, I couldn't comment on that. You're probably better to, different countries have different licensing requirements. And so what might be, it might be that it works and it might be that there's data there, but it's not licensed for us to use it here for that purpose. Any other questions anyone wants to ask?
Sir, whether triptan or clofenac can be given in a severe headache patient before diagnosing the hemorrhagic stroke?
Sorry, so if someone's got, before you've diagnosed a stroke, if you can give, what was the question? Could you just repeat the question, if that's okay? I didn't quite catch it.
Adult patients with severe headache,
Yeah.
Before diagnosing the hemorrhagic stroke, whether clofenac or triptan can be given
Okay, so well,
on
the thing is,
another assumption of other cause.
yeah, so if you're confident that they have got migraine, then you could give them a triptan. If you think someone might have a stroke, that's going to present in a different way, isn't it? Because you're going to have some history of a weakness or slurred speech, or on examination, you're going to find an abnormality. So remember, one of the key diagnostic criteria about migraine, you're only going to say it's migraine if it's not attributed to another cause. There isn't something in the history or the examination that makes you think, okay, this fits with a TIA or a stroke or a giant cell arteritis, because if it does, the management of those is going to be different. So if you think it could be stroke, that's an emergency. They need to be seen. They need to be, go to hospital, right? Because that could be fatal if you don't diagnose and manage it, especially depending on the type of stroke. Whereas if they fulfill the diagnostic criteria for migraine, you're confident it's not that, then yes, great. A triptan would be for an adult first line with something.
Yes, thank you.
You're welcome. Any other questions? Okay, well, thank you very much, everyone, for being engaged and involved, and getting involved with the interactive case, getting involved with answering questions. I do hope it's been helpful. Please do fill in some feedback for the program, and I wish you all the best with the rest of your certificate, the rest of your program, and your other sessions. Thank you so much. Assalamu alaikum.
Thank you, sir. Assalamu alaikum. Take care.
You're very welcome. Wa alaikum salam.